Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. Sorry it's a bit later than normal, just had a clear wax training course today. I do try my best to upload a video every day at the moment. I've just got so many procedures on my iPod, and if I don't offload them, I won't have any memory to take any new videos of exciting procedures. So I'm just trying to get through my library and archive of videos. So this is a patient who attends, I believe, perennially, so every year, typically for the right ear. So this is the right ear we're in. The patient also, on this occasion, advised that he's experiencing occlusion in the left ear when laying in bed at night. So occlusion is when you can hear internal sounds, whether it be your own voice, but we call that autophony. But when you're eating or chewing, or your respiratory sounds, or sometimes your heartbeat or your pulse. And they wanted me to obviously examine the left ear as well. Now, we're just focusing on the right ear first, and they've also obviously come in for this ear. This is a regular build-up of dead skin. Now, the patient has got an abnormal eardrum. You may have seen this patient's ear in previous videos, earlier videos. And at the end of the procedure, I'm just going to annotate the patient's eardrum and explain the different landmarks and what's exactly going wrong. So this patient's got very dry skin, wax. It's quite medial towards the eardrum. It does crust over. It's quite a satisfying type of consistency of wax to remove because it offers little resistance. When you put a suction probe, hover it over the wax, just like here, it just sucks without me having to do much work and to manoeuvre and peel the wax off the canal wall. So this type of dry wax and skin is quite a satisfying one for clinical ear care specialists to perform. So the occlusion has been removed. I'm just using a fine end suction probe just to peel off any dead keratin around the edge, and you can just see the view offered by the endoscope. It's stunning, and you can see the eardrum in the distance, and you should already be able to detect the abnormalities. So the right hand side of the eardrum, that's all scarred. We call that tympanosclerosis. The left hand side of the eardrum, that's retracted, so it's sucked in. So the patient's got eustachian tube dysfunction, which causes negative pressure behind the eardrum in the middle ear, a bit like when you're on the aeroplane, when you're descending. So the eardrum's got sucked in, and you can see the hammer bone, which you can normally see when you examine a normal healthy ear. So the hammer bone is the malleus, what we call the malleus, and that's in the middle, and that's attached to the eardrum. But we can also see the patient's stapes, so that's the smallest bone in the body, and that's because the eardrum is sucked in so much, it's wrapped itself over the head of the stapes. So the stapes has different parts to it. You've got the head of the stapes, which is the lateral parts of the part of the stapes bone most closest to the eardrum and the entrance of the ear. And interestingly, the patient's middle bone, so there's three bones, the hammer, anvil and stirrup, otherwise known as the malleus, incus and stapes. But the incus, the anvil, as you may be aware of it as, it's missing, it's eroded. And the reason why that's eroded, I'll come back to that in a moment. So let me just explain what we're doing in the left ear. So the left ear was look pretty healthy, but just got this little piece of skin and wax on the drum. Now, I just removed it for the patient, just in case that was the cause of the occlusion. We did do a pressure test to see whether the patient's got a blocked eustachian tube on this side, so a tympanic retraction as a result, and that can cause occlusion, but they don't, although that can be intermittent. Therefore, the patient's attended. I thought, let's just try and remove that. Let's see if that improves the patient's symptoms. The patient did get back to me actually and said that since I removed that piece of skin on the eardrum, it has improved their occlusion at night. For some patients it wouldn't have, because it's only a minimal amount, but fortunately for this patient it's done the trick. And I'm now just mopping up around the edge, but to be able to remove that off the eardrum with the eye clear scope, you can see how the view it offered. We had a training course today, so if any of the delegates are watching, well done and congratulations, you all did stellar today at the training course. It's been quite a satisfying day actually, because a few of the other past delegates I've trained, they're now starting to upload videos and procedures on social medias, and I saw a couple today. So again, guys, if you're watching, well done. It's great to see that you're getting on well with the eye clear scope and endoscopic earwax removal. So I'm just mopping this up, and in a moment I'm going to show you a still image of the patient's right eardrum. So the first ear, and we're going to just quickly go through the anatomy and the abnormalities for you. So here we are, we've got a still image of the patient's right eardrum. And so to the right hand side of the eardrum, that's the scar tissue, that's tympanosclerosis. So the patient has a history of chronic ear infections, and sometimes as a part of the healing process, you can get scar tissue. So it's a buildup of calcium deposit, call it calcification of the eardrum, otherwise known as tympanosclerosis. So that's to the right hand side of the eardrum. The left-hand side, the eardrum, is not scarred, but it's severely sucked inwards. I don't know if you can see around the ridge on the left-hand side. So the patient has got a blocked eustachian tube. It's a long-standing problem. It's chronic. The patient has seen ENT before. There's not much more they can be able to do. And so the blocked eustachian tube is a narrow tube at the back of the eardrum that connects to the back of the nose. It's the pressure equalizer in the ear, and it's got blocked at the back of the nose, which has created a vacuum behind the eardrum, so there's no air, so the eardrum gets sucked in. In this particular patient, it's the back part, so on screen, the left-hand side, the posterior portion of the eardrum is really sucked in. It's quite a severe retraction there, and you can probably just see where the eardrum should be on the left, the ridge. And you can see the hammer bone, which is the most prominent bone, and you, as I mentioned earlier, you typically do see the hammer bone in people's with healthy ears. But to the left, you can see there's a piece of bone there, like a circular portion. Obviously, it's annotated, and that's called the head of the stapes. And in between the stapes and the hammer bone, there should be another bone called the anvil, or what we call in the medical field an incus, but that's been eroded. So why has that been eroded? And it could have been that the patient had a glue ear, and it's a middle ear infection, and the infection caused the incus to become eroded. It got disease. We call it necrosis. Oh, it could have been that because this eardrum is so sucked in, that it wrapped itself around, like it is at the moment on the head of the stapes, but obviously previously the anvil would have been there, and the eardrum so tightly adhered itself and wrapped itself around the anvil bone that it stopped the blood supply. So you have blood vessels there, and it just constricted it. It suffocated the anvil from receiving the necessary blood and the nutrients from the blood and the oxygen to stay healthy, and as a result it slowly eroded. So it's both plausible causes. I hope you enjoyed that video, guys, and take care. Speak soon. Bye.